many kids will say they just want to ride a roller coaster. They're not able to participate in normal kid things because they just don't fit, behind in the car of a roller coaster. So it can be little things that really are huge triumphs for them.
I have a lot of respect for people in the body positivity space, and I wholeheartedly embrace the idea that we have to stop blaming and shaming people for how they look and for their body size. I think that's very important, but to some degree, it does sometimes overlook the real negative impact that severe obesity has on people's lives, their ability to be kids and get out there and enjoy their life.
Yeah.
And honestly, I had never even thought about things like riding roller coasters. I personally am a wimp and won't near a roller coaster. So it never occurred to me like, there are people out there that want to do that and can't.
We'll go together and I'll hold your purse for you while you go.
Right? Yeah, that's my job.
I'm not getting on it myself. Yeah, no, thank you.
Welcome, friends, to the Eat Your Greens with Dr. Black podcast. I am really happy you're here. This is episode number 35. So if you're a returning listener, I really appreciate you coming back and I appreciate your support. Thank you so much for being here. If this is your first time stumbling across my podcast, I want to give you a big welcome. You have found your way to an excellent resource for learning about the amazing health benefits of plant-based nutrition. Now, today, I'm doing something a little different. I'm not talking about diet. I'm doing a 2-part series on the treatment of pediatric obesity. For those of you who don't know, in 2023, the American Academy of Pediatrics released their first ever clinical practice guideline laying out their recommendations for the treatment of children and adolescents who are affected by obesity. And let me tell you, it garnered a lot of attention and not just a little bit of controversy. So I want to talk more about it because it's relevant to me as a pediatrician who's interested in helping my patients who are struggling with obesity. But I really want people to understand what the guidelines are about, what their purpose is, and why they're so important. In one of the episodes, I'm talking to a pediatric obesity medicine specialist. And today, I'm talking about surgical treatment of pediatric obesity. A lot of people are curious about this, but other people have some biases. Let's just take a minute to set our biases aside when it comes to thinking about should children have surgery, who should have it, at what age. What I would like you to do is just listen with the intent to learn. I want you to come away with a greater understanding of what the indications for pediatric surgery are, who qualifies, and why it's important. I want my listeners to cultivate a better understanding and some compassion for what kids and adolescents are going through when it comes to experiencing pediatric obesity and why surgery might be an important and appropriate treatment for them. I'm joined today by Dr. Ann O'Connor. She's a pediatric surgeon who specializes in pediatric bariatric surgery. I am really excited to have her on the show. So, without further ado, let's get started. I'm really happy to have you with me today, Dr. O'Connor. You know, it was interesting because you and I worked for a good 6 months, if not longer, to try to meet. And it just seemed like the universe was working against us. I mean, there was, of course, the usual scheduling conflicts. We're both very busy individuals. But at one point, I was supposed to go down. I don't know if you know this. I was supposed to go down and meet you in San Antonio. And we had torrential rainpour and flash flooding that day. Like, I was like, I'm not getting on the highway and driving to San Antonio.
I wasn't aware of that. Well, thank goodness.
Yeah, that's why it got. And then you actually came to San Marcos and were visiting the local physicians to talk about your practice. And that was the one day. I almost always bring my lunch to work. And that was the one day that I did not. And I had already left to go get lunch. And I wasn't even aware that you were there. And when they told me, I was like, oh, you're kidding me. I missed her again.
And it was funny for me when we were there, the front staff, as I was leaving the practice, said, "Oh, Dr. Black is interested in obesity." I was like, "What? I need to meet her."
Yeah, and we had been trying at that point for a while. Once we finally did sit down and talk, though, it was a great conversation, and I feel like we just clicked our treatment approach, our sort of, I think, personalities and approach to caring for our patients aligns on a lot of levels. Even though I'm not a surgeon, I just feel like we really connected. So I appreciated that, and I'm beyond thrilled to have you on the podcast today to talk about this. And I appreciate how busy you are. Thank you so much for joining me today.
Oh, my pleasure. It's great to have an ally in the fight. And it's my pleasure to talk about, my favorite thing. So that makes it fun.
Just to introduce you, Dr. O'Connor is a native of Chicago. She did much of her education there in Chicago. She's had an impressive career. She's board certified in pediatric surgery, but also obesity medicine. And if you're not aware of the difference, medicine is basically non-surgical treatment. So it's very interesting that you have pursued both board certifications. And so Dr. O'Connor has a 20-year surgical career, much of it spent as the director of pediatric surgery and adolescent, metabolic, and bariatric surgery at Lurie Children's Hospital in Chicago. Now, Lurie Children's is a little bit dear to my heart. I talk about my special needs daughter often, and one of her very first epilepsy specialists was up there in Chicago. They have a great pediatric epilepsy program there, amazing doctors. So I have this little piece of my heart that just really still fondly remembers our experiences up there. So I'm sure that their pediatric surgery program is just as top tier as their epilepsy program. It's an amazing center. In 2022, Dr. O'Connor moved down our way. She's now based in San Antonio, and she's the division chief of pediatric surgery and the director of adolescent metabolic and bariatric surgery here in San Antonio at what we fondly call CHOSA, Children's Hospital of San Antonio, which is affiliated with the Baylor College of Medicine. Did I get it all right?
I think so.
Now, I want to start. What is metabolic and bariatric surgery? Can you tell the listeners a little bit about what exactly that is?
Yeah, absolutely. And thank you again for the opportunity. I specifically, when we were deciding on a name for our program, we wanted to make sure we included the metabolic portion in the title of the program, because you can't really operate for weight loss without understanding that what you're really doing is operating for metabolic improvement. Meaning, if it was just a matter of taking out a part of the stomach and people eat less, then why would we have to operate? You just eat less, right? So we know that metabolism is the foundation of everything. So that's one of the reasons why I wanted to include that in our program, and also why I personally wanted to get educated about obesity medicine and metabolism and nutrition, so that I could actually present my patients with the most factual information. So that's where that came from. That's also the name of our national society, is incorporated in that name as well for the same reason.
So combining the two, it's not just chopping parts out. I mean, people think of that's all surgery is. You're just chopping something off or cutting it out or sewing it together, but there's a lot more to it. It's the effects are just anatomical. It's
absolutely
wide-ranging effects on the body when you do the surgery. And we'll get into the actual surgery a little bit more in a minute. The other thing I wanted to ask you is, tell me about the obesity medicine part. There's a stereotype in medicine that, surgeons just want to be in the OR. They're not interested in anything else. So why would you, a surgeon, why did you pursue a second certification?
Yeah, part of that's sort of true. I mean, we do like the operating room. That's what we do. But any surgeon will tell you the hardest part of surgery is not the doing of the surgery. It's the decision-making and the education required to make sure you're doing the right thing at the right time for the right person, for the right reason. So as I started getting more and more involved in the surgical procedures and realizing that in my patient population, there weren't a lot of people that had extra training in obesity, I thought, well, the best way to put those two things together is to go and get educated. And the way it works with the certification is that it's not a separate, complete training program. Like I haven't gone back to school to be an internal medicine doctor, but there's a certification for people with an interest in medicine related to obesity. So that could be any number of specialties, doctors that do other kinds of things that have an interest. So that's how I kind of went down that pathway, because in order to kind of understand the literature and participate in management, you sort of need to be educated about those things. And we don't learn that in medical school, really, or in surgery training.
What are some of the medical problems that you see in pediatrics that would be different from the strictly surgical approach?
A lot of our patients, when you operate for weight management, there are some patients, there's a spectrum, right? Some patients are very, very obese. Their disease is very severe, but they're not yet sick with other problems. But we know those problems are coming. We know that their lives are going to be affected later. Then there's some patients who really have a lot of metabolic problems, who may not be as heavy as some patients, but they're very ill. Things like diabetes, high blood pressure, sleep apnea, arthritis, asthma, all of these things, skin problems, infertility, they all go together metabolically. And so I've had patients I've operated on with medical issues that are the reason we're operating. The weight loss was almost secondary. So you have to realize it's not a one size fits all. You have to apply the principles and be thoughtful about what your goals are for surgery.
So that goes back to what you said about it's not just weight loss surgery, it's metabolic surgery. The reason that you're taking a patient to the OR may not have anything to do with their weight. It may be all these other health complications that go along with and often have the same root causes, right? I like to say it's not that obesity in and of itself directly causes diabetes and heart disease. It's that they share the same root causes. And so if you can address one of them, you can also have a positive impact on the others.
Absolutely. There's, it's rare to have a patient with only those metabolic problems and also not obesity. We see it every now and then, but it's far more common the other way around. So you have to always keep those things in mind so that you can operate safely for patients.
Describe the type of procedures that you do. People are interested, like what is it?
Sure.
They may have a vague idea of the different types of bariatric surgery,
right.
But what is the most common one used for pediatrics? And so just tell us a little bit about what is it that you do to the human body?
Sure. Exactly, right. Well, that's an easy 10-minute podcast right now. If you look in the online or through the research, you're going to see there's a lot of different operations that have been described, lots of them. And back in the day, and when I say that, I mean about 30 years ago, the gold standard operation anywhere in the world, including for adolescents, was the gastric bypass. So when you think about weight loss surgery, they sort of come in two different varieties. There's the type that make you not absorb your food well. Then there's the type that makes you not able to eat very much. So they all fall sort of in those two categories. There are some that are both types. The gastric bypass is an example of that. It works by making the stomach very small, and then we create a sort of a rerouting of the intestine so that the normal pathway for food and digestion is bypassed. The food mixes with the nutrients downstream from its normal pathway. So people lose weight because they can't eat much and they also don't absorb. That's a great operation. It is a great operation, but it has a lot of potential complications. So about 30 years ago, people started figuring out there was another operation that became popular called the gastric band. You may have heard of the band. The band was a little plastic device that was easily technically put into the patient. It would go around the top of the stomach and inflate with a little port. And so then if you overate, you would vomit, which is not nice and also is not permanent. And the minute the band was removed, patients gained all their weight back. So pure restriction wasn't a great idea either. And there were a lot of complications. And in fact, for teenagers, it was so obvious that it was not a great operation that most of the big centers for children pulled out of the research trials, realizing there were so many complications. So then along came my favorite operation for adolescents, and which is now the most popular operation worldwide, which is the sleeve gastrectomy. And what that means is that in the operating room, I remove about 80% of the stomach, but I leave it hooked up the normal way. So there's no bypassing, there's no rerouting or extra complicated surgery, which makes the risks way lower. And the results show that the weight loss between the bypass and the sleeve are the same, if not similar, maybe within a few pounds of each other. So why wouldn't you want to do an operation that was safer and just as effective as some of the other operations you've seen? So nowadays, the sleeve gastrectomy is the operation that most pediatric surgeons will do for adolescents, and it really is the most common operation worldwide. We don't really do bands anymore, and bypasses are reserved for those patients who really have to have that procedure for other medical reasons.
Going back to the clinical practice guideline from the AAP, who is a candidate in the pediatric population specifically for bariatric surgery? Who, if I'm a doctor seeing these patients, who should I consider referring to you?
Right. I think that's an important topic because the first thing I would say is that there are certain patients that are very high risk that should be referred to a specialist to at least have a discussion so that the family is properly educated, they understand what their options are. Education is probably 90% of my practice with my patients. The guidelines for surgery are very similar. They sort of mirror what we do in the adult world. So anybody with a body mass index over 40 would qualify to consider bariatric surgery, regardless of whether they have health problems, because their degree of obesity is so serious that we need to be talking about interventions. That index is calculated. It takes into account, how heavy the person is. It's not just the number of pounds they weigh, but how old are they? Are they a boy or a girl? Are they tall or short? What age they are? All those things matter to calculate that BMI number. Sometimes we see patients, so anybody with a BMI over 40, understanding that a normal body weight goes up to about 25. Sometimes we see patients who have a lower BMI but have medical problems. So if they have a BMI between 32 and 35, but they also have significant medical problems like diabetes, high blood pressure, sleep apnea, those are the big three, those patients we would also consider. And then every now and then you'll meet somebody with a BMI that's not that high, but they have other medical problems like elevated blood pressure in the brain related to their weight. And so the treatment for that problem is weight loss. Those patients do great with surgery. So if they meet those criteria, and then for adolescents, the thing we think about is teenagers. So we typically operate, the youngest age range would be age 13 up until age 19, at which point most patients are, I guess, considered adults chronologically. So those are the patients that usually see adult surgeons rather than me as an adolescent surgeon. Does that mean that every 13-year-old should have an operation? No, there are a lot of things that have to be in place for adolescents that are sort of different than for adults. A young child will come to an office appointment because their parents make them come. That may not be their idea. They may have no problem with their body image. They may be perfectly happy the way they are. And we have to understand those things and not force surgery onto them. On the other hand, there's plenty of very mature 13-year-olds who are ready to take care of their health and are advocates for themselves, and we want to be able to support them. So the youngest patients I've operated on have been 13 years of age, and they've done great all the way up to age 19.
And what is the process that a patient would go through? So I've identified someone who might be a candidate. I've referred them to you. Walk me through it. What is the process in your office to help not only you understand their needs, but help the family and the patient understand what's happening?
Sure. So our patients will come for their first office appointment, and we always warn them they're going to be long because I talk a lot and we do a lot of fact finding. So our program consists of a sort of a multi-disciplinary group of people. There's me, of course. We have a nutritionist We have our bariatric coordinator, we have a social worker, we have a physical therapist, and we have a psychologist. And then we have access to other medical specialists like endocrinologists and kidney doctors and things like that. So at the first visit, they will see me and they will see our nutritionist. And we spend a lot of time sort of getting a dietary history, figuring out what they do or don't know about surgery. Oftentimes, the patients are surprised that their obesity is bad enough to consider surgery. This may be the first time somebody's told them that there's a problem that's a serious problem. Those conversations are hard to have with people. I think a lot of doctors avoid them. So we spend a lot of time getting to know each other and talking about basics about surgery and weight management. And then we usually will embark upon a medical workup if it's not already been done, including labs and x-rays and things like that, sleep studies. And we see the patients every month thereafter. Monthly, I think, is important because it results in some accountability. So patients know they're coming back to see me and they're like, oh no, I better do what she says, right? You know, there's some of that. But also it's ongoing education. And each month we have a different topic. For example, the second visit is where I sort of talk about exercise and how important it is. And it's not just a joke, and it's not every type of exercise. We spend a lot of time, and our physical therapists see them and help them, and so on. Diet, how to eat, those kind of things, when to eat, why sleep is important. Then at some point in that process, if the patient decides that, yes, they want to go forward with surgery, then we complete the package. And that usually takes about 5 months, 4 to 5 months for people to kind of be ready. And then we submit to the insurance companies for approval and schedule them for surgery. And then afterward, we see the patients very regularly. It's also unlike a lot of the adult programs where there's a checklist, you have your operation and then have a good life. I'm latched onto them as long as they'll come back. So we see them a week later, a month later, 3 months later, 6 months later, a year later, and so on. So it's a pretty intensive, time-consuming process, but I think that helps people. It sort of self-selects the patients that think this is just, cosmetic, or I'll have this operation, I'll never have to think about it again, that kind of thing.
So you're really understanding that it's a complex process that needs to be done thoughtfully and with the patient on board.
For sure.
That's an
and
important
the family
part.
on board.
Right.
Yeah.
And the family.
Yeah. These are children, they're not deciding what groceries are being purchased that day. They're not deciding how often they're eating out. So there's a lot of education and social support that's required. It's expensive to eat well. Those kind of things we have to calculate in.
Let's start with the negative. Let's just get that out of the way. What about complications? What have you seen, or what are the, national rates of complications of this kind of surgery?
Sure. That's easy to talk about because there's not a lot of complications, but when they occur, it's a big deal. So the most uncommon complication, which is the thing we fear the most, is called a leak. So anytime you operate on the stomach and you remove a piece of it, really for any reason, whether it's weight loss surgery or cancer or whatever the reason, there is the way that procedure is done technically is usually with a stapling device that seals off that stomach that stays behind. We take out the piece we don't want. We leave behind the staple-lined stomach, which makes it kind of a high-pressure system for a while. So if there is a problem that would cause a hole to open up in that staple line, that would be a very bad complication. Acid will come out of the stomach into the abdomen, and people have died from that. And it used to be that was considered too high a risk to take. But when you look at the literature, you'll see confusing things. There's a range anywhere from 2 to 30% leak. I mean, that's insane. That's like saying you have a 2% chance to get hit by a car or a 30% chance. I mean, that numbers are meaningless, but the real data shows a far lower leak. You see big series of 600, 700, 800 patients with 1 or 2 leaks. So we also know now there are things you can do to make that risk lower. Number one, as much as I am a obesity surgeon, I am a ardent anti-smoker. So smoking, vaping, those things all damage the blood flow to the stomach, and there's a higher risk of leak. So the first thing I work on with my patients is to stop smoking. Second, patients with a BMI in the really severe ranges over 50 have an independently high risk of leaking. So when I see kids like that, I try to work to get them below that number before we operate. And then third, if patients have really out of control diabetes, we want to get that under control. Just like it would be for any operation, those risks are higher. So that's how we handle our leaking risk factors. And then other risk factors, like for any surgery, bleeding, for example. Sometimes patients have a little bleeding related to removing the stomach. It's not usually serious, although it's certainly something we have to pay attention to when we're operating. Once you get beyond those two things that are kind of unique to bariatric surgery, then the standard risks, like for any operation, a wound infection or a blood clot, those kind of things. And we manage all of that at the time of the surgery to try to make the risk as low as possible.
And so long term, speaking of long term complications, I once had somebody tell me, and I'm pretty confident this is not true, but I just want to throw it out there because I think it's what people are talking about, or you might see on social media, things like that. So somebody told me that there's a very high rate of opioid addiction following weight loss surgery.
Yes, I know what you're talking about. And this was kind of knocked around in the media as the opioid crisis has become very clear. I tell you that's not the case because my patients get no opioids. So they are discharged home on Tylenol and Motrin, and that includes in the hospital. So on the first night of surgery, they may have medication to help their pain while they're waking up and recovering. But the next day, as they start drinking and moving around, really the pain is not the issue for them. It's just learning how to drink without getting sick to their stomach. So the opioids made that so much worse that many years ago, I just stopped using them. We don't need them. Patients do great. They are never readmitted for pain control problems. It's always about drinking and nausea.
Is that common? What is the adjustment period? What do they go through after the surgery, just adjusting to life?
Sure. That's a great question. I always tell them the same thing, which is that the first 3 or 4 days after, you're going to be mad at me. You're going to not like me. You're going to say, why did I do this? Oh my gosh. Because of the nausea and the drinking problems. Mostly they're scared of pain, but that's not it. After about day 3 or 4, life starts to get much, much better. They're drinking better. They're comfortable. At that point, most people aren't even taking Tylenol or Motrin anymore for pain. And now they can focus on drinking. And you know how this is, like most people would rather have pain than be nauseated. Nausea is not fun. And we have a lot of medications, and I think I have a good cocktail now, so I've really not struggled with that as much. But that's the most common problem. I usually see people back about 10 days after surgery so that I'm seeing them after that phase is over. And then we start moving them through the stages of advancing their diet so as to give them more satisfaction but not stress that new stomach. So they start with liquids right after surgery, and then we slowly work them up through a soft diet until about 2 months after surgery, they're on a regular diet.
What can they expect after the recovery period in terms of hunger, how they're eating?
Right.
What is the relationship to food and eating following the surgery once all the healing has been done?
Right. And that's really a critical point of our education before, because if your mindset and eating strategies don't change, guess what? You won't lose weight and you'll gain it back. And that's with the best operation on earth. So with teenagers in particular, that's a lot of work goes into that discussion. We teach patients that right after surgery, they will often, for the first time ever, feel full. Many patients with obesity are essentially never full. It's not a normal pathway. Hunger signaling and satiety, feeling full is not normal. When we do the surgery, they're often the first time having that feeling. And it's a very strong feeling in the beginning. Sadly, it doesn't last for the rest of their lives, but for the first 3 to 6 months or so, that's a very strong behavioral modifier. So I tell them, when you eat or drink and you get that feeling, that's the stop time. Immediate stopping of the meal. Sometimes that's only a 10-minute meal, maybe a half a scrambled egg in the beginning. And that your brain needs to learn that, yes, that's the portion we're talking about. There's not something wrong with me that I can't finish it. There's not, we don't need to be depressed or sad because what you used to be able to do, you can't do. So that's your body telling you we're done, put it away. Because as time goes on, that feeling gets harder to get. It takes more food to make you have that fullness feeling. And if you haven't learned that your portions are your proper portion, you'll start to eat more and you'll eat to the point where you get that feeling and all of a sudden you're eating 3,000 calories a day, and we've kind of undone the benefit of the surgery. So a lot of time is spent with them, especially in the post-op period, trying to avoid behaviors that will turn out to be bad ones in the long run. That's why the follow-up is so important.
Right. Absolutely.
Yeah.
For everything. Have you had any teens push back against that because now they're different from their peers, or, they're not able to do the things that they like socially that their peers are doing?
Yes. And we talk about all that as well, because lots of kids that come to us have depression or anxiety. It's so common nowadays that that can be made worse sometimes after bariatric surgery. There's reports in the adult literature of higher suicide rates and other addictions that can develop. So we are very upfront and talk about all those things because we want them to understand that their feelings are normal, that they're having. They may have friends who no longer want to be their friend because they're not, the obese friend. We may have differences in their social lives. Some teens don't want to tell their peers they've had this because it's a personal decision, and therefore their behavior in social situations when it's different draws attention to them. So we talk about all those things, understanding that ultimately they have to come to a place where they're doing the right things for themselves because that's the right thing, and they get empowered by that tool. And when that happens, it's the greatest thing. Patients really do well, and they have their own control of their bodies and their mental health. A lot of anxiety gets better for those kids. So we talk about how surgery will absolutely affect your body image, the way you relate to other people. Teens have those concerns anyway, and so when we make big changes, it definitely affects them.
So we talked about complications. What about some success stories? How does this impact their life in a positive way? And do you have any, without breaking patient confidentiality, any success stories that you'd like to share?
Oh my gosh, yes, lots of them. But I will tell you a funny story. I guess you'd call it a success. So I had a patient who was really in the very serious range of a BMI around 60. And this patient had a hard time doing anything, walking, wearing gym shoes, stayed home from school a lot, homeschooled, but was a great kid who really sort of got motivated, got educated, lost a bunch of weight before we operated, and after surgery did spectacularly well. Now, I always tell my patients, if you ever feel like you need to go to the hospital after surgery, please call me directly, because sometimes hospitals, ER doctors, they may not have any idea what these operations are. They may have never seen a teenager who had a sleep. So I get a call at about 2 a.m. on a weekend. Of course, I don't know the number because, I don't keep everyone's number. And it's my patient telling me they're on their way to the emergency room because I think I broke my collarbone. And I said, well, okay, when did that happen? Yesterday? Well, how did it happen? Jumping out of an airplane. So I was like, oh my God, wait a minute, this is so-and-so? And the patient's like, yes, I was jumping out of an airplane with my friends yesterday and I really hit hard and it kind of hurt, but now it's really swollen. What do you think I should do? I said, oh my God, stop jumping out of airplanes. First of all, does your mom
Number one?
Because, here we are trying to save your life so carefully, and then you're launching yourself out of a perfectly good airplane. So it was kind of an example though of, how life is completely different for our patients, and it's really great. They do very well. They lose weight. They keep the weight off as long as they're following up and continuing the hard work, which is often, I think, much harder than the actual recovery from the surgery would ever be. And so with the right patients and the right motivation, they do very, very well.
And I imagine that it was really, really hit home. I mean, we're going from on the one extreme, I imagine fairly socially isolated, homeschooled,
Yeah,
whether it was physical limitations or psychosocial limitations of just getting to school and feeling comfortable in that setting, to now I have a friend group and I'm out doing things like jumping out of airplanes, like being active, leaving my house.
right.
Now that I think that's an amazing example. I assume it's an extreme, but I think it
It is,
highlights
but it does
a
highlight and
negative
often,
impact.
yeah, it often, I'm sorry to interrupt you. Yeah,
That's
I
okay.
also think of all the kids who come, and when I ask them what are their goals, they're funny. Sometimes they want to get into a prom dress that fits, a year from now. And I ask them about non-scale victories. What are some things you look forward to? And many kids will say they just want to ride a roller coaster. They're not able to participate in normal kid things because they just don't fit, behind in the car of a roller coaster. So it can be little things that really are huge triumphs for them.
I have a lot of respect for people in the body positivity space, and I wholeheartedly embrace the idea that we have to stop blaming and shaming people for how they look and for their body size. I think that's very important. And I have worked hard to overcome some of that weight bias that I have and weight stigma that I know it's just how we're taught in medical school,
Mhm.
especially 20, 25 years ago
Yeah,
when this was not a conversation anybody was having.
right.
So I really respect that and think it's very important. But to some degree, it does sometimes overlook the real negative impact that severe obesity has on people's lives, their ability to be kids and get out there, enjoy their life, do things, participate. And
Yeah.
honestly, I had never even thought about things like riding roller coasters. I personally am a wimp and won't
Yeah,
near roller coasters.
I
It
don't
never
either.
occurred to me like,
I
oh,
always
there are
tell
people out
them,
there that want to do that and
we'll go
can't.
together. We'll go together and I'll hold your purse for you while you go.
Right. Yeah, that's my
I'm not
job.
getting at it myself. Yeah, no, thank you. It's true. There's a sort of a fine balance between how you talk to people. We're often very, very judgmental. We don't mean to be. And I'm not talking about just doctors. Even parents of children with obesity will often say things that are hurtful without realizing. For example, well, just think about how much prettier you'll be once you're not so heavy and all the boys are going to want to date you. That's a terrible thing to say to a girl as if her whole value is based, her attractiveness is based purely on her weight. And I understand the intention, but you can see how that's really hurtful. And we have tried to train our staff to interview people in motivational ways rather than in judgmental ways. Oftentimes, young kids that are really heavy or obese are treated like they're much older children because they're larger, and people forget this is a 13-year-old you're talking to. I mean, this is a 13-year-old kid. They have different outlooks, and you have to really be aware of that. Otherwise, the shutdown occurs and we're done with the topic, and that's that. There's no going forward then.
Yeah. Respect the patient and understand what motivates them. And it's
Yeah,
a challenge. I'm glad that we're having this conversation about it.
definitely, for sure. Same thing with families. Often I'll hear from families that, well, we're just all big people, so my son or my daughter is just like the rest of us, so what's the big deal? That's a little bit of that's a mountain to move for sure, because then you have to figure out ways to help them understand the social, the familial issue, and this one problem is just part of a much bigger problem.
Right. And the causes of obesity are so complex.
Yeah,
It's partly genetic. In fact, there's a pretty significant genetic component, but the social determinants, the culture of fast food. I always talk about this in my podcast that I really support healthy nutrition, but I understand the barriers and the obstacles that are in place. And as much as I would love everybody to just have a plant-based diet and eat a reasonable amount of food, I truly believe that that would help a significant number of people. I also understand and appreciate that it's not as easy as just saying, well, just eat some more greens. Eat your greens with Dr. Black and you'll be
Right.
fine.
Right.
I really always want to remember how complex the issue is, what the barriers are in place for people, and that we need to look at all of the different treatment modalities out there. How can we help our patient and what's the best for each individual patient, and set aside our preconceived notions about what
Right.
ought to happen. What I think should happen is not necessarily what can happen or is best for that individual patient.
Yeah, exactly. And I think if you understand it, like, I don't know anyone who struggles with obesity that's happy about that. I don't know a single person that says to themselves, boy, I just want to be as big as I could possibly be. I mean, it's just so understanding that if it was such a simple matter of, less in and more out, we wouldn't be having this discussion. We wouldn't be seeing skyrocketing increases in obesity. And that doesn't mean, oh, throw up our hands, it's all genetics, there's nothing we can do. No, there's a lot we can do. There's a lot we need to do. And those discussions are what is difficult. When there's a barrier that is insurmountable, the patient can have all the information in the world that they need to make a good decision. They just can't make it. If I have a teenager who spends half of their time with their mom, who's cooking careful food and making them really watch their portions and is really helping, and then they spend the other half of their social life at their dad's house or with their grandparents who take care of them during the day, and it's a whole different ball game, what's that child supposed to do? They're trapped in a situation they can't control. So,
or they're
so we have to
trying
look
at
those
home,
things.
but then they go to
Right.
school.
Yes,
And
they go to
the
school
school
where the
food
food's not great.
environment is terrible.
Exactly.
That's a whole different topic.
Yeah.
I need a whole nother podcast.
We'll get on that one later. Yep.
This has been a really helpful and insightful conversation. I have learned a lot about the process, and I'm excited to interact with you more, work with you more, talk to you about which patients I should consider referring. So I think this has been very helpful for me personally, and I really hope that it's been eye-opening and helpful for my listeners as well.
I appreciate that. And I hope that that people understand that the referral to someone like me who has this interest and treatment option for some children is not based in a desire to experiment on their children or, it's not meant to be judgmental, but it is meant to be educational and therapeutic. And sometimes that involves surgery. And we are really happy to take care of those patients that choose that treatment choice.
And I also try to communicate, and this is true of anytime I'm referring somebody to a surgeon, it doesn't mean you're going to walk in their office and automatically just be scheduled for surgery right away. You're having a consultation. You're going to have a conversation. This is what we do, why we do it, and is it or is it not an appropriate option for your child? So I want
Right.
people to understand that. If I do a
For
referral, it's a conversation that's started and it's beneficial. And if you ultimately decide, nope, that's not right for me, well, you've had the conversation and you come away with more information about what your options are.
Yes, for sure. And a lot of patients, for that reason, exactly, they don't want to come because they're, concerned that we're going to just somehow suck them into the operating room and, and do that. And that's not the case. Or sometimes the other way around, where they think that there's a simple solution and just next week we'll fix this problem and then we're good. So we sometimes we have to educate the other way too. Yeah.
Goes both ways.
Yes, exactly.
All right. I have one more question that's not related to your surgical practice.
Uh-oh.
You mentioned that you like to play poker and you are a weightlifter. So tell me more about that. That was like, oh, that's fun.
I don't know. I like poker a lot. I used to play lots and lots when I lived closer to Las Vegas. And I had a home game with like 25 girls that would come every month. We played pretty religiously for about 12 years. I just love the game. I love being able to outsmart people. And I just think it's great. It's fun. However, I'm not that great at it, so I've never done, crazy high stakes things. Like I'm too cheap to, spend the mortgage on the poker table, but I could spend all day at a table with my couple $100 and be
well, that just
happy.
Sounds like wisdom to me.
It's a lot of fun. I enjoy it. The weightlifting thing, yes. So as you know, I myself and everyone in my family has struggled with obesity my entire life, as long as I can remember being alive. And I've been eating right and doing all the right things for long enough that I thought to myself, well, I need to change the way I'm exercising. Something has to be different because I'm already eating right and I'm already doing all the things I'm supposed to do, right? I'm a specialist. So why is this a problem for me, right? So
Oh,
I
even
started weightlifting.
specialists?
Yes, it's
Even
true. Even
specialists struggle?
doctors, yes. And that's what
What?
often families are like, oh, you look like you also. I'm like, yes, I too work on it. But yeah, especially with the recent literature that's been out about weightlifting and body mass exercise being a much better exercise for weight loss and metabolic improvement. So I started. I go 4 times a week, 5 in the morning to my gym. I have a trainer, and we're grinding it out. And you know, I'm feeling great. I've lost a bunch of weight, which is great, even better. But putting on lots of muscle and really getting kind of hooked on it.
I've
I'm
also
preaching
seen
to the
a
choir.
lot of this. Yeah, you're talking about the newer research and information, and I'm seeing a lot of it, especially for at my age, postmenopausal women, and the importance of maintaining your muscle mass and your strength and your balance for so many things. So it's
Yeah.
on my list. I haven't yet taken the steps. I have some body weight exercise type things here in the house that I do when I'm able to, but I'm inconsistent. We're just learning. We're just learning about the importance of muscle to your
It's
overall
so
health.
important. And I look at it, I don't think I'm going to get into a competition to try to deadlift more than anybody, but it's more about, functional activity so that, when you get old and fall, you can get up. And when you're in the operating room on your feet all day, you can still function and that kind of stuff. So yeah, I got the bug.
That's amazing. Great.
Yeah. Thank you.
Well, I really appreciate your time. I know your schedule's busy. Thank you for carving out a piece of your day to talk to me. It's been a great conversation,
Thank
and
you. My pleasure.
I hope we get
This is
to
great.
talk again in the future.
I would love to do that anytime. Thank you very much.
Wow, what an amazing conversation that was. Dr. O'Connor has a knack for bringing clarity to a complicated process. I know people have some very strong opinions about whether or not teens should undergo such a drastic treatment for their weight. And I sincerely hope that after listening to this episode, you have a little more appreciation for how complex of a problem it is, the great impact that obesity can have on people's lives, their quality of life, their ability to just be a kid, and understand that nobody is just jumping into this as a quick fix. The entire process of qualifying for surgery is a long one. She said it's a 5 to 6 month process, and it focuses not only on the health issues, but also the family's opinions and needs, and most importantly, the patient's needs, thoughts, and desires throughout the process. They have a great team of people that help support the patient in terms of education and mental health, other medical issues that may be associated. It's not just as simple as get an appointment, have the surgery, go on and live your life. There's so much to it. And I think that we really need to double click on that. Nobody is taking a blasé or irreverent approach to this issue. And surgery is one treatment option that may be valuable and life-changing for patients who go through the process and end up having the procedure. So thank you for listening today. I hope you have a greater appreciation for this complex issue. And I look forward to continuing this conversation and exploring all of the ways that we can help people who are struggling with obesity and the wide-ranging health complications that may be associated with that. Of course, nutrition is the foundation for all of it, whether or not somebody has surgery. So I'm going to keep talking about why you should eat your greens. I hope you come back again to hear more episodes. Please feel free to leave a comment if you'd like to, but let's keep it positive. I understand that there are some strong opinions out there, and I want to have an open-minded, thoughtful, accepting conversation that appreciates all sides of this complex issue. Thanks again for listening, and don't forget to eat your greens. Please be aware that this podcast provides general health information about nutrition and feeding of infants and children and is meant for educational purposes only. It's not intended to replace the important relationship between a parent, child, and pediatrician. If you have concerns about your child's nutrition, health, or growth, please consult your doctor.